Hello, and welcome to What's New in the Treatment of Spinal Muscular Atrophy. This is the second podcast in a three-part series titled New Therapies, New Considerations, Supporting Comprehensive Coordinated Care in Spinal Muscular Atrophy. I am Vanessa Battista, Senior Nursing Director and Pediatric Nurse Practitioner at Boston Children's Hospital. And joining me today is Dr. Julie Parsons, co-director of the Neuromuscular Clinic at Children's Hospital, Colorado. This program is supported by an educational grant from Biogen. Partners for Advancing Clinical Education is providing this activity for 0.25 ANCC and AAPA credits. To receive your credit for this program, please go to practicingclinicians.com/SMA2. I'll repeat that link for you at the end of the discussion. Today's learning objective is to evaluate the efficacy, safety, and appropriate use of new and emerging treatments for SMA. So let's dive in. Dr. Parsons, can you tell us about the possible treatment options for SMA?
Absolutely. This is an incredible, exciting time where we now have 3 FDA-approved therapies to treat patients with spinal muscular atrophy. The first agent that was approved in 2016 is called nusinersen or Spinraza. Nusinersen is indicated for all patients of all ages with spinal muscular atrophy. Nusinersen works directly on the SMN2 gene in order to increase splicing and increase production of functional SMN protein. Nusinersen is given intrathecally, it's given via spinal tap, and it does need to go through a loading period of being given at initiation, day 15, 30, 60, and then quarterly for life. We know after more than 80,000 doses given to patients with SMA that it's an amazingly safe drug with very, very few side effects. The main side effects tend to be related to post-LP syndrome. It is indicated to do safety labs with nusinersen. It's an antisense oligonucleotide. And in that class of drugs, there have been other issues for other patients involving kidney and blood issues. So we do safety labs prior to treating children. We look at PT, PTT, platelets, INR, and we do look at urine for urine protein prior to each dose. Nusinersen has been shown to be very effective in babies who were treated pre-symptomatically. Again, when patients have more symptoms, we expect that their response won't be quite as robust. And if a patient is an adult or seated patient, we do continue to see benefit, as noted through both clinical trials and real-world data that we have now, that there is continued benefit. But certainly, the outcomes and benefit are most dramatic when this drug is given to newborn babies who are pre-symptomatic. The next drug that was approved and in the United States is indicated only for newborn babies up to the age of 2 years of age is a gene transfer product. This is called onasemnogene abeparvovec or Zolgensma. And this agent actually works to replace the missing SMN1 gene. Onasemnogene abeparvovec is an agent that consists of a viral capsid, an adeno-associated viral capsid number 9, AAV9. And within that capsid or that carrying platform is inserted the SMN1 transgene. And then there's a promoter. So that is the composition of onasemnogene: capsid, transgene, and promoter. This agent is trophic or specific for motor neurons. So recall that Spinal muscular atrophy is a disorder of the motor nerves. With onasemnogene, it is an intravenous administration of the drug, and it's given just once. However, we know that about 5 to 15% of babies actually have antibodies to AAV9. And so we're not able to give this agent if AAV9 titers are high. And we test this titer, an antibody titer, when babies are born to see whether or not onasemnogene is an option for them. There are some side effects that are associated with onasemnogene, and it mostly relates to having an immune response to the agent and to the AAV9 capsid. So babies and children are treated with prednisone the day prior to treatment, as well as for the first 2 to 3 months. Most children will develop some upset stomach, sometimes vomiting, fever within that first week after treatment with the agent. They are at risk for developing something called thrombotic microangiopathy, typically at the end of the first week, beginning of the second week. Most all children will develop a transaminitis, and we monitor their transaminases quite closely. And we look at that really throughout that 2-month period. We look particularly at around the 6 to 8 week period. We monitor very, very closely from both a physical exam standpoint as well as from looking at lab monitoring. We are, again, concerned about the TMA. We're concerned about liver injury. And I think I failed to mention thrombocytopenia, which can also occur transiently, typically in these babies that are treated. If the babies are doing well, we then begin to taper the steroids off over 2 to 3 months after therapy. And most children can come off of the steroids successfully. This treatment is only able to be offered once because it is a gene therapy, and antibodies will develop once the agent is delivered. We think at this point, looking at the ongoing clinical trials with onasemnogene, that the treatment is durable and that we continue to see effect in children that are treated out at 8 to 10 years. So we'll still look at that and follow these children very closely in the future. The drug that was most recently approved for newborns is called risdiplam or Evrysdi. This medication also works on the SMN2 gene and helps with alternative splicing. And interestingly, risdiplam is an oral agent, so it's probably the easiest agent to deliver to patients. It's well tolerated. Early on, some of the patients will have some GI disturbance, maybe with some nausea or upset stomach. But in general, those kinds of symptoms tend to disappear over time. Prior to dosing with risdiplam, we do make certain that children do not have any liver issues, as this is metabolized through the liver and can cause some difficulty if there is any kind of hepatic impairment. The other concern with risdiplam is that there may be some ill effects on spermatogenesis. So there is a caution about using this in men, and that there may be some teratogenic effects. So it's not to be used in pregnant women. But the good news is that we have 3 agents, all of which have wonderful outcomes. Again, with all 3 of them, they're best when given early in diagnosis so that we can treat children and babies prior to them developing significant weakness and other symptoms.
Great. Thank you so much. Can you tell us a little bit about what additional therapies are coming down the pipeline?
Absolutely. It's amazing that even with 3 FDA-approved therapies, that still there's a lot of work going on to see if we can still improve the lives of these patients. So now we have talked about the agents that are approved are SMN-directed therapies, and there are off-site therapies that are in clinical trials currently. These involve anti-myostatin, anti-promyostatin, and these agents would work on the muscles. So there's nothing really wrong with the muscle structure, but if the motor neurons are not stimulating muscles become atrophied. So the concept behind the myostatin inhibitors is if we can give an agent either with injection or with IV, then we would be able to allow muscle to grow larger. And we would suspect that if the muscles are larger, that there would be increased force, increased strength, and decreased fatigue over time. So if either of the 2 current agents under study or under clinical trials end up seeming to be safe and efficacious, then we would really look for these therapies to be adjunctive therapies, not replacement therapies, for the 3 SMN-directed therapies that I mentioned earlier.
Wow, it's really amazing how many things are happening in the field. It's very exciting. So thank you for telling us about them. And thank you for talking with me about this important topic today. And thanks to all of you for listening. To claim your credit for participating in this activity, please go to practicingclinicians.com/SMA2, and that's a numeral 2, and complete your post-test there. Again, that's practicingclinicians.com/SMA2. Thank you. I would also invite you to listen to the 2 additional podcasts in this series where we discuss early diagnosis and coordination of care. Thank you again for joining us today.